So Dr. Thorpe did me a great service by giving you a background. I'm David Rye. I'm a professor of neurology at Emory University in Atlanta, Georgia. And I've been doing sleep medicine for about almost 30 years. And he did a good service by describing how we go about defining narcolepsy by this test that measures how sleepy one is during the day and giving one opportunities to do that in a sleep lab in a controlled situation. And also a lot of the other issues that he brought up. I am going to talk a little bit about absent slides to help. The history of how this naming came into play, and touch on, I think, some of the issues he brought up which were at the edge of sort of maybe some of the controversies. That leftover sleepiness that can't be treated, is that the same illness, or should we all just put everything in one big bucket and call it narcolepsy and consider it the same disorder with the same biology? Or are we better off trying to split those patients, and splitting them meaning giving them maybe different names or designating them as having different biology, and those may be nuances and they may be considered academic by some, but with new treatments, some that I'll talk about, different than the ones Dr. Thorpe spoke about, and the fact that the prognosis would be different. I mean, as a patient or a family member, I think we'd all want to know what the prognosis was for our 18-year-old child who is labeled narcolepsy. Is this a child who's going to develop cataplexy and sleep paralysis and vivid dreaming? Or is this a child where that's not really an issue? So in an instance like that, knowing that the hypocretin is absent is a potentially useful piece of information going forward. And in terms of the issues related to how the disorder is caused or what contributes to it, the heritability for type 1 narcolepsy that Dr. Thorpe spoke about, which is the narcolepsy with cataplexy, there is a heritable component to it, but it doesn't explain very much of the disorder. I mean, he mentioned that you have to be exposed to a virus, for example, and you hear something on the news that says, geez, if you have narcolepsy, your child is 4 times more likely to have narcolepsy. You think, gosh almighty, that's 400%. But for a disorder that's only 1 in 3,000 people, 4 times more likely is only about 1 in 600. So you're still very unlikely from a genetic argument to be that much more likely to get narcolepsy, type 1 with cataplexy. Whereas the other disorders, what is referred to as narcolepsy without cataplexy, and the potentially associated condition I'm going to talk about is idiopathic hypersomnia. There, whether you're in France, whether you're in Atlanta, Georgia, or whether you're in Prague, in the Czech Republic, essentially 1 in 3 of those people carrying that diagnosis has a relative within 3 myoses, so within a cousin relationship that has the same disorder. So the knowledge and the difference between narcolepsy with cataplexy or narcolepsy without cataplexy and lumped with idiopathic hypersomnia is more to me than an academic discussion. Because as a parent, if I had a child, I'd want to know what to expect, because idiopathic hypersomnia, type 2 narcolepsy, remission rates are 15%. Narcolepsy with cataplexy, they're 0. Narcolepsy with cataplexy tends to get better with age, kind of counterintuitively, I think. If you measure older adults that have the narcolepsy with cataplexy, the results on the sleep tests are better, whereas the other patient population is worse. So these are more than just academic issues. And then finally, I'll tell you about some of our work that sort of points to the fact that treating the second group differently is also useful. So it's interesting when you go back and look at the history of narcolepsy. The name was probably described in the late 1870s by Westphal in Germany. And then a French neurologist, Gillenau, and it was often referred to as Gillenau syndrome, described it in 1880s, early 1880s. And he clearly describes cataplexy, but he also describes another patient who was a portly, short man who probably had sleep apnea before anybody knew what sleep apnea was. But the other case was pretty clearly with the cataplexy, narcolepsy. But it's very dramatic. We don't see it very often in clinic, but if you do see it, and somebody is, you know, I wish I had a video to show you, but it is, as Dr. Thorpe says, pathognomonic. And then later, at the same time, an interesting neurologist who was eventually knighted, a Victorian neurologist in England named William Gowers, described a condition described as somnosis. These were patients he referred to that couldn't get out of bed, weren't dramatic because they couldn't fall to the ground because they were laying in bed asleep. And they had true hypersomnia. They were, as he described, they never woke up fully. They were in a trance. They were in a torpor. And that's not what narcolepsy is. Narcolepsy is generally, I'm not going to disagree with Dr. Thorpe that there's some residual sleepiness, but this is beyond a little residual sleepiness. These people have a huge difficulty waking up. And there's terms in our language, sleep drunkenness, you know, it's, in German it's Schlafkrankheit. In Icelandic, it's Svefndrungi. So all these cultures have a word for sleep drunkenness. And all you need to do is Google alarm clocks and see how many people make sonic boom alarm clocks or helicopters that fly in the sky, and you have to grab them, or you have to fix a Rubik's Cube puzzle to get the alarm to go off. It's real, right? There's companies making products for it. So, you know, we can't say that, at least in somebody's mind, it's real, right? So these folks didn't really get as much of attention as these folks with cataplexy. Cataplexy is so dramatic and dreaming, right? Freud was around the same time, very dramatic. But these other folks really didn't get a lot of attention. And then dream sleep wasn't described in terms of what the characteristics were physiologically until 1953 by Nathaniel Kleitman and Azarinsky at the University of Chicago, which is my alma mater. And interesting, Jerry Vogel in 1960, who was also at the University of Chicago and actually was at Emory when I first got to Atlanta, showed, measuring brainwaves and other features of dream sleep, that people with the type of narcolepsy that Dr. Thorpe was talking about would go right into a dream in the middle of their day. Little physiological hints. So that muscle tone would go down the eye. You ever watch a baby's eyes? Because they dream a lot, babies, when they're first born. So Jerry noticed this, and he was a psychiatrist. And at the time, there were also a lot of other psychiatrists involved in sleep and psychologists, and there were a lot of other affective illnesses, for example, depression, schizophrenia, bipolar disease, where people had dreamlike experiences. And so people went and looked at those folks and recorded them, and sure enough, they had some of the same tendencies to fall into a dream. Well, how does that happen? And basically, there's been a hypothesis since that time through at least the 80s and 90s, and still borne out a little bit, is that what keeps a brake on us dreaming are chemicals like noradrenaline, things like serotonin, dopamine, okay? And these are the antidepressants, okay? Interestingly, Jerry Vogel showed that if you took patients with primary depression and didn't give them drugs, but just took away dreaming, the depression got better. You woke them up. You'd record them in the sleep lab, and you'd watch on the sleep study to see when they went into a dream, and if you woke them up, they got better. All the antidepressants do what? They get rid of dreaming. They hold a brake down on dreaming. All right, so what do? Is they increase these chemicals called monoamines, dopamine, right? Dopamine, I say to patients, is your brain's cocaine, right? It's the happy, reward, motivation, let's go and do it. There's noradrenaline, there's serotonin, these mood-altering drugs, but they all help with wakefulness. They all get rid of tend to get rid of this moody depression, okay? So then in the 70s, with that backdrop, people were starting to do this NAP test and establish this NAP test as a norm. But this is, I think we can all relate to the fact that there's confirmation bias and we do things, the results are going to depend on what we think is going to happen. We all have a bias going in, right? I'm only going to do this test on people with narcolepsy who I think have cataplexy. Well, guess what? You record a lot of dreams on these NAP tests. Well, what happens if I do that to you, or you, or you, irrespective of what your complaint is? And if you do that, and we didn't find this out until 2006, about 2.5% of women and 4.5% of men grabbed off the street will meet criteria of this test for narcolepsy. You really think there's that much narcolepsy out there? I guess if the test is useful in terms of being specific. So given what I told you already, what other sorts of disorders, if we cherry picked them, might have a lot of dreaming? Depression, a relationship to somebody with depression. It's very heritable, this propensity to go into a dream. You can induce first-degree relatives by giving them drugs that increase acetylcholine. And in fact, one of the first studies I was aware of at Emory when I got there, Charlie Nemiroff was chairman of psychiatry, was the inclusion criteria for the patient to enter was a parent with a propensity to go into a dream too fast. That's an amazing inclusion criteria for a study. So this speaks to the fact that depending on who you record, you may get a lot of people that have this dream stuff. And then what is it really that you're treating? Because these medicines that Dr. Thorpe spoke about, save for gamma hydroxybutyrate, all increase monoamines. They all inhibit REM. They all promote wakefulness. So we can call it depression, we can call it narcolepsy, we can call it, oh, you got a little bipolar. I mean, you can see the problem that comes up with naming when things are so non-specific, right? It's not a specific marker. The hypocretin is. And that may be a very good reason to measure hypocretin. Okay, so where did we come into this more than we did? So it turns out Parkinson's patients, we were the first group that showed if you take random Parkinson's patients, do the test, about 1 in 3 have narcolepsy. That's been shown by 2 other groups. Myotonic dystrophy, different brain diseases, you see this. People at the end-stage kidney disease do a very similar thing. So there's all sorts of ways, depending on who you test, you may get a false result, what we call false positives, okay? Now you may end up treating them the same, but got to be careful when you look at the results out. Do they respond to the same? Is the story, does the, as they get older, does it stay that way? That sort of thing. Now, getting to Dr. Thorpe's comment, I think is very true about narcolepsy, having these residual symptoms, and getting back to Dr. Gower's about somnosis. There are patients that don't, if you take narcolepsy with cataplexy, they sleep 9 to 10 hours across 24 hours. There are a group of people that sleep 12, 13, 14, 15, 16, 17, and then they have these alarm clocks. They probably sleep longer, right, if they could. Sleeping Beauty syndrome, you've heard about it from maybe some other folks that use that name. And if you talk to these patients with narcolepsy, I had one, I was going to maybe show a video. It was made a really interesting comment. This is a kid that we saw last year. It's on YouTube. You could probably look it up. appeared on Georgia Public TV, and he said, modafinil, all it does is keep me from falling asleep. And you're like, well, hell, what are you complaining about? That's what we want, right? But he wasn't happy. Because he's talking about what Dr. Thorpe was talking about, right? We think about yes, no, I'm awake or I'm not awake. But there's this whole continuum, right? And color and flavor to being awake. It's not just a dichotomous yes, no. His quality wasn't good. Or patients refer to it as brain fog that's still in my head. I feel fake awake. I don't take a nap, I take a coma. Okay? The hardest thing I have to do every day is get out of bed, wake up, right? When does a nap quit being a treatment and start being a problem of the disease? So these people take 2 and 3 and 4 hour naps, or sometimes they won't because they're so afraid that once they fall asleep, they can't go back. Okay? So the analogy we think of, well, we think that these people are essentially, they still have some substance in them that's rendering them sleepy. Okay? So you can drink all the espresso you want after that frat party or sorority party and you had a half a keg of beer, but you're not awake and safe enough to drive home. That's what these people, I think, are trying to explain to us when they take these medications that don't quite get them there. And so as a neurologist, and we heard about loss of hypocretin, we're all very comfortable with the idea if I have a stroke or I lose a neuromuscular junction or a nerve, I can't do something. It's a loss of function. So when the science came along and said, geez, you lose hypocretin, that's a loss of function. You can't stay awake. It all made sense. It reinforces the bias of thinking of loss of function. But we started wondering, well, why are there some of these folks where you pour amphetamines into them, double the recommended doses or double the threshold, plus other medicines, and they still sleep 30 hours? And you go, and you look at them and you go, well, they're stumbling into the wall. They can't wake up. They look drunk. They're sleep drunk. There's something around that's making them that way. There's an endogenous something. So years ago, we measured that, and it looks very much like a sleeping pill. Activity in the spinal fluid you could detect that in a dish, experimentally, looks like what Valium would do or what Ambien would do. Now we've been sort of hot on the trail of what that is. The good news is that there's an antidote for overdosing Valium, just like there is for opioids and heroin called Narcan, and this is called flumazenil. It's IV. It's used if people can't wake up after surgery, for example, sometimes, or somebody accidentally took too much Valium. And it's available intravenous. So our challenge was trying to make it into a formulation useful for people. And that's a conflict because I have all sorts of licensing with some companies and royalties from it. But it's useful in some of these patients. And not all of them, and we've published on this in sort of open label fashion. People come so far from 46 states and Canada and 7 countries otherwise to see us because we have a local compounding pharmacy that just makes it. It's not available in any kind of mass fashion, and I'm not involved in that. But some of the results have been very, very dramatic, and maybe I was looking in my slides, I sort of said, well, how can I explain to the audience how effective? So since 2013 till this August, separate from ourselves, almost 1,000 people have been prescribed flumazenil out of this pharmacy in Atlanta. There's about almost 200 that have been taking it for 6 months or more. That's not covered by insurance. It's all out of pocket. They could get all these other drugs that some of which we've heard about, paid for by insurance, but they don't work. And they're paying for this out of pocket. So they're pretty desperate folks. Some of them are physicians. And so we're in the process of figuring out what this endogenous substance is that the body makes that binds to this receptor and causes us to be sleepy. So it's a gain of function, right? Not a loss of function. There's too much of this. All right, so forget the loss of function. And so we've made some progress. We have a candidate molecule right now that looks very promising. We have to confirm it. Unfortunately, machines and instruments break down at inopportune times. But we bought this peptide and applied it, and we could see that it enhanced, like Valium does, the current of the transmitter GABA at nanomolar amounts. And as you increase it, you see more at nanomolar. So that's 10 to the minus 9th concentration. So it's very sensitive. And we could reverse that with 3 drugs. Turns out that flumazenil works, but we also serendipitously found out that certain antibiotics work. When did we find out about penicillin causing seizures? World War II, skull wounds, exposed brain, liquid penicillin, some folks got seizures. And that's because certain antibiotics inhibit this natural GABA system in the brain. So your brain gets more excitable, the brake's gone, right? And so clarithromycin, which is like Z-Pak, used for kind of upper respiratory infections, turns out as a side effect, we found out by serendipity, caused insomnia in one of our patients who was on 120 milligrams of dexedrine and couldn't stay awake. But she got put on clarithromycin by her primary care physician, and she couldn't sleep. And when he did the science on it, it turned out it was a case. And it turns out other antibiotics do a similar thing or interact with the brain. So another one that we've become very familiar with is fluoroquinolones. So the fluoxetine medicines that are sort of bladder down kind of antibiotics have a very similar effect. It is actually looked at about 30 years ago in terms of seeing if there was any promise for those drugs to have a benefit for helping keep people awake. It was abandoned. So there is a lot of supporting information. And really right now, in the process of working with several companies with different disease targets, but trying to identify, it's not all the patients with quote unquote narcolepsy or all the patients with idiopathic hypersomnia. And that gets back to the naming problem. Do you lump or do you split? Because if you lump, you end up with a big heterogeneous goo. And if you put a goo into a clinical trial, maybe 20% do great, just like in our clinic with flumazenil, but it's not meant for the other 70% or 80%, or certain disorders. So we're in search of sort of who the target population is. These are very dramatic effects when we see them, and that's what we're in the process of doing. It may sound academic, but if you fall into that category, you don't want to go, as Dr. Thorpe said, and is very, very true, people are on a long path to a diagnosis of narcolepsy. Repeat testing, here's 5, well, how many medicines did he mention? 5, 6? Let's try these 6 medicines. They're all approved for narcolepsy. What's that? 2 years, 2.5, 3? And what if none of them work? Wouldn't you want to know that you had this other, this potential disorder that's treated totally different, right? Don't push the gas pedal. Do I need amphetamines and more norepinephrine and more dopamine? Okay, well, I can go get Shell, I can get BP, I can get Esso, I could get Citgo. They're all pushing the gas pedal. The other approach is essentially, no, we got to take the brake. The parking brake's got to be disengaged before the gas pedal's going to function at a full efficiency. And that's the difference, okay? That really puts people in different boxes with different hopes and different treatments and all sorts of different implications. So I think, I don't know where I am on time, but sorry I didn't have slides. All right, so any questions I'm happy to take. Thank you for your attention. Yes, sir.
Is it Remanzo, the new drug that you had some experience, is it an add-on to replace the drug?
Yeah. So the question is, can you use this, take the foot, take the gas pedal or take the parking brake off in whatever fashion you can? I would say in about 80% of people, you need still some gas pedal. There's maybe 20%. So a good example is the very first case actually was written up in Discover magazine from the summer of 2013, if you want to pull that out. She was a lawyer who had to take a leave of absence because she very high-end law firm in Atlanta, and within 6 months we figured this all out in her, got her back to work. She was on just flumazenil, got back to work, made partner, now has a child, and married in her 30s, late 30s now. But she was on over 120 milligrams of amphetamine and 600 milligrams of modafinil at 110 pounds and would sleep 30 some hours. And a strong family history a bit. I wouldn't say strong, but certainly there. In first-degree relatives. And so she did well on flumazenil by itself for about a year, and then we added back 100 milligrams of modafinil, and that's where she's been essentially, other than when she was pregnant. And we got her actually through pregnancy on clarithromycin because there is some safety data on the antibiotic during pregnancy. She was the one we found out about the clarithromycin serendipitous. It's always nice to go look at serendipity as the other lesson behind this, especially in very, patients who are, very on, good historians. Other questions?
I was just going to ask about, this is the first time I've heard about vivid dreams associated with narcolepsy or hypersomnia. Is that also in any other types of things, or is that quite unique for?
Yeah, well, no, I mean, there's some, types of dreams, and when you get to the, quote, vividness of it, it is kind of an interesting, how do you measure that? The short story is Parkinson's patients oftentimes have this sort of between a hallucination and but they're usually fairly benign, right? They know they kind of very colorful, they enjoy it, they know it's not real, and they don't get bothered by it. I mean, so what is that? Is that like a little dream mentation, in the evenings when they're in bed? There are certain medicines that can do it. Interestingly, dopamine medications, things that enhance dopamine. Parkinson's is less dopamine, but they're taking these dopamine medicines. But just normal folk, people with restless legs, which we'll hear about in a minute, that take dopamine can occasionally have vivid dreams from their maybe dopamine. Yes, ma'am. Yeah.
And I'm wondering if this is what he's got. Narcolepsy, maybe from vaccine or something.
Yeah.
It hasn't been diagnosed or anything.
Right.
And then there's a grandparent who I think might be a
hypersomnia.
Yeah.
Right.
Because he's falling asleep at 9 o'clock
Yeah.
at night, and then he'll sleep and then.
Once you start looking for it, I mean, I hate to go back and talk about, biases, right? But when you look at the people that describe narcolepsy with cataplexy, as I said, it was very vivid, it was pretty unambiguous, but even before we had sleep tests. And always the index case of the family is the person with cataplexy. And then there's these other folks in the family who are sleepy, lots of them, but they think the index case is the patient with cataplexy, which is asked backwards. So the very first family in the Mayo Clinic that they showed, with 4 generations, had 15 affected family members. The family with narcolepsy. Only 2 of them had cataplexy, and they're trying to tell you that narcolepsy is what's heritable in that family. Of course, this is even before you could measure naps and stuff, right? So they're focused on this group of cataplexy, because it's very obvious, right? It's very dramatic. So this is this human tendency to be, you know, confirmatory bias. And you're like, well, geez, 13 of them didn't have it. So wasn't that what was heritable, right? Gets to the point. Anyway. All right, I'm done.